So this is a case of HFpEF, that is heart failure and preserved ejection fraction. How can I say that? Because the patient is having symptoms of heart failure like shortness of breath, and the patient is having bilateral pedal edema, and echo shows an ejection fraction of more than 50%, and there is LVH and there is grade 2 diastolic dysfunction. All these things literally confirms that you're dealing with a case of HFpEF, that is heart failure and preserved ejection fraction. So in HFpEF, there is not even a single drug that can improve survival. So the fantastic four that you talk about, none of those drugs that are used in HFrEF is going to improve survival in patients with HFpEF. But there are certain drugs that can address the symptoms and it can reduce the heart failure hospitalization. For example, diuretics can relieve the congestion so that the patient feel comfortable. We are going to use loop diuretics for that matter. You can add thiazides also, but loop diuretics are the preferred choices for volume overload states. And what about SGLT2 inhibitors? They're going to reduce heart failure hospitalization in patients with HFpEF. They don't have any effect on mortality and survival, but they're going to reduce heart failure hospitalization. So I can add especially the dapagliflozin and empagliflozin. What are the other drugs that can actually reduce heart failure hospitalization, but again, not going to improve survival in patients with HFpEF? It's going to be MRA. Mineralocorticoid receptor antagonists like spironolactone, eplerenone. Findenone has not been studied yet for this situation, but spironolactone, eplerenone has been shown to reduce HFH, heart failure hospitalization. And of course, the GLP-1 receptor agonist, semaglutide, and the combined dual GLP-1 GIP agonist, that's called tirzepatide, both of them have been shown to have a role in reducing heart failure hospitalization in patients with HFpEF and obesity. Okay, so the conditional recommendation is obesity. So in those patients, this can have some effect as well. So these are the drugs that have some beneficial effects, not with regards to survival, but with regards to reducing HFH in patients with HFpEF. So option A, perform coronary angiography to rule out ischemic cardiomyopathy, not really required at this point of time. And ischemic cardiomyopathy typically will be presenting with low ejection fraction and not with high ejection fraction. And digoxin to enhance myocardial contractility for what? Myocardium is already contracting well, EF is good. So I don't want digoxin. Anyway, digoxin, even in HFrEF, is not going to improve survival, right? And initiating ivabradine to reduce heart rate and improve diastolic period. That's not required as well at this point of time. Ivabradine in HFrEF itself is only conditional. And here, most of the studies say that they have not even studied about ivabradine and HFpEF. So I'm not going to go for that option. I'm going to choose option B as the right answer for this question.